extremely interesting.
Many thanks.
Reason for debate for all the morning, but we have to carry on. So we come back to you. Thank you for joining, despite the call. Right? See you later.
Thank you.
So we carry on now with Khalid Betty. He was the first number one abstract. CRP as predictor of complicated acute pancreatitis, reality or a myth. This is a paper recently published. Khalid, good morning.
Good morning, Professor. Good morning, everyone. Sorry for being late, and thank you very much for giving me a chance. Can you please?
So go ahead, please.
Can you please see my slide? Can you please confirm?
Yes. Can you increase the volume a bit?
Is it better now, Prof?
Yes.
Yeah, that's good.
Okay, thank you.
Okay. Go ahead, please.
Right. So, as Prof mentioned, the title of the presentation is C-reactive protein as a predictor of complicated acute pancreatitis. Is it a reality or a myth? So, I'm Khalid Bhatti. I'm ST5, currently working at Royal Blackburn Hospital in Northwest. I started my training actually in Carlisle as an ST3. So, we'll go through the presentation. Right, so I would like to thank some of the authors, Rami Ahmed, Moyed Ahmed, Kamran, Shafiq, Abdul Monem, Amreen Kausar, and Prof. Canalo for their contribution. So I think last time we presented about the complicated acute pancreatitis, same month, almost the same date. We know that the acute pancreatitis is a very common presentation, and reported incidence is about 13 to 45 every 100,000 people. Now, pancreatitis could be very mild, or it could be moderately severe or severe acute pancreatitis. So the basis of classification are actually Atlanta classification system, where we divide mild acute pancreatitis having no local or systemic complications as compared to moderately severe, where we have systemic complications for less than 48 hours, or severe AP, where we have systemic complications for more than 48 hours. This system was devised, and it has certain advantages because we can discuss these patients with hub and spoke using hub and spoke model, and these patients have a higher morbidity and mortality, so they require more care as compared to the patients with a mild acute pancreatitis. Now, we recently reported, I'll show you the next slide, that there is another way of classifying these patients, and that is mild versus complicated acute pancreatitis. Because what is common between these two classification is the presence of complications. So these complications could be local or systemic less than 48 hours, or it could be systemic more than 48 hours. And all these patients who are complicated acute pancreatitis, they need to be discussed with the hub for their remote care. And these patients, they have a higher morbidity and mortality. We actually presented, and we have published this from the same hospital from Carlisle, the management of complicated acute pancreatitis, the role of hub and spoke model. So according to that data, which was presented last ASU prize ceremony as well, the reported mortality in the literature is 30 to 40%. And from our center, it was progression rate from mild to a complicated acute pancreatitis was 22%. So almost every fifth patient was going into complications, which could be systemic or it could be a local complication. Now, 33% admission rate and 11% mortality. So these figures tell that complicated acute pancreatitis is something serious we need to look into. So that is the reason that there has always been an interest in developing some predictors which could be multifactorials like a Ranson, Glasgow, Apache, and nowadays we're using a biceps scoring system. But there has been interest because these all multifactorial, they are difficult to calculate, and they requires calculation and investigations at admission at 48 hours as well. So there was interest to develop actually a single biomarkers, and CRP is one of them. Similarly, NLR ratio has recently been investigated for the purpose. Now, if we talk about only CRP as a predictor of complicated acute pancreatitis, then we know this is released from the liver, and it's in response to any inflammatory condition affecting the body. And its first utilization was reported by Mayers in 1984. So it's not something new. It has been in use for many, many decades. Now, there is a conflicting reports in the literature, because some people say that it's a best predictor at 48 hours. Some say we can use it as at admission CRP. And nowadays there has been report saying that actually it's the interval change. Now, there is another problem that the cutoff values, some suggest it could be 180 to 190, and others suggest it should be more than 150. So, the predictive value depends upon sensitivity and specificity. So we wanted to see that what's happening in our data. So we wanted to compare the diagnostic accuracy and the predictive value of CRP at different timings and cutoff values. And we wanted to compare with the other multifactorial single predictors like NLR ratio, Glasgow scoring system, and CT severity index. We use Atlanta classification as a gold standard. So any patient who had a complication was taken as a positive, be it a local complication or a systemic complication. And every patient who did not have these complications as a mild case, that was taken as a negative. So we have a positive cases and negative, as you would suggest, as we expect in any case of any test. So it was conducted at NCIC. We had been collecting this data over a period of 5 years from 2014 and 2018, thanks to Mr. Shafiq. So we used the same data which we presented previously. This didn't require any ethical approval, and it was a part of an audit project approved by the department. So the variables included in this study was the age, gender, cause, morbidities, CRP at admission, CRP at 48 hours, any change in the CRP at 48 hours, NLR ratio at admission, Glasgow scoring system, and MCTSI score. Anyone who is more than 18 and met the criteria was included in the study. Now we defined, as I mentioned earlier, mild AP without any local or systemic complication, while complicated AP, acute pancreatitis, by the presence of local or systemic complication. The MCTI, which is a modified CT severity index, that was calculated by using the online system, which was described by Mortelli. So CT scan in every patient was done, where it was done was after 72 hours. So SPSS version 20 were used, and we used these descriptive statistics, which included mean, medians, averages, and modes, and inferential statistics. So in inferential, first of all, we compared the two groups, like uncomplicated and complicated acute pancreatitis, based on age, gender, comorbidities, and etiology, making sure that these groups are comparable, and there is no significant difference between the two groups based on these variables. After that, we used area under the curve analysis to compare the diagnostic performance, and then we measured sensitivity, specificity, positive and negative predictive values, and diagnostic accuracy. The p-value less than 0.05 was taken as a standard. So in total, we had 496 episodes in 401 patients. But for the current analysis, that data has been presented already as a clinical outcomes. But for current analysis, there were 225 patients which met the criteria, plus they had all the variables available, because it was a retrospective analysis, so we were missing some of the data. So 170 cases, those were missing some relevant data, they were excluded. Now, coming to the demographic features, we can see that the male and female ratio was almost equal, with the female slightly higher. Etiology, biliary pancreatitis, as we accept, was the commonest cause of pancreatitis. Based on Glasgow scoring system, there were mild cases of 52%, severe was in 16, and this was based on Glasgow scoring system, and there were 68% were actually missing. MCTI I showed these numbers, but according to the revised Atlanta classification, we had 47 patients as complicated acute pancreatitis and 178 as mild cases. So this was our gold standard based on which, or using this as a gold standard, we divided and we measured the diagnostic accuracy of all those CRP values against this. The mortality from this data was 4%. Now you can see from this slide that there was no difference based on age, gender, cause, or comorbidities, which could be possible covariables. Area under the curve, we can see that the best performance was shown by the CT scan, CT severity index. That was area under the curve was 0.9, 2 actually. And second best was the CRP at 48 hours. And third best performance was shown by change in CRP at 48 hours. That is the interval change more than 90. This is a tabular form, and we can see that the modified CT severity index has an area under the curve of 0.9 with a p-value of 0.000, and CRP at 48 hours 0.7, statistically significant again, and interval change was 0.67. So these values 0.7, 0.67 otherwise are not a great test for doing any screening and diagnostic values. Anything more than 80 or 90, that 0.9 or 0.8, they are usually significant. They are clinically useful. But looking at these Glasgow scoring system, NLR ratio, and CRP admission, they were quite non-diagnostics. We were more interested in the positive and negative predictive values. So looking at MCTI, 100% positive predictive value and 92% negative predictive value. Then the Glasgow scoring system, the negative predictive value was less because some of the cases they at 72 hours they don't show any major fluid collections or pancreatitis signs, but they may come with systematic instability. The patient may be in cardiovascular shock or could be having sepsis or SIRS at presentation without CT scan findings. That's why negative predictive value is slightly lower. But where they are present, they are diagnostic of the severe pancreatitis. Glasgow scoring system, and you see all these values, positive predictive values for Glasgow CRP at 48 hours, more than 150 cutoff or more than 190 cutoff, and interval change more than 90, and NLR ratio, they show a very, very low positive predictive values. However, we can see that the negative predictive values are more than 80% in every case. Now, we find from these, these findings that CRP admission had a very poor diagnostic accuracy. At 48 hours, the cutoff values like 150, 190, and interval change of 90, they also failed to reach a positive predictive value of greater than 50%. But NP, the negative predictive value for these parameters was quite good, which is more than 80%. So let's look one by one. So CRP admission, we saw that the area under the curve was 0.4 with a p-value of 0.74. And this has been reported, this is not something new, this is not new finding. This has been reported by Fisk as area under the curve of 0.51 on the first day and 0.67 by other authors as well. We know why it happens, because the hepatic synthesis of CRP peaks at 36 to 50 hours. So this is not, this is easily explainable by the pathophysiology, that CRP would not be very much predictive or diagnostic of a severe acute pancreatitis in case at day 1. So it should not be used as a prediction model. Now at 48 hours, if the cutoff value we take is 150, then the area under the curve was 0.7, statistically significant. The reported values are slightly higher, that is 0.84 and 0.9. But if you look at the PPV at 48 hours at this cutoff, it is only 30%. And if we look at the reported PPVs from the literature, they range from 37% to 73%. So it's a very wide range, which in itself is an evidence that it's not viable predictive in complicated acute pancreatitis. What could be the reason? Because of the the lack of specificity, because there could be other reasons for having raised CRP at 48 hours, which could be cholecystitis, cholangitis, UTI, and sometimes the nosocomial respiratory tract infections. So again, CRP at cut of 150 at 48 hours are not a best predictor, positive predictor. If we take the cutoff to 190, will it improve its positive predictor value? It's rather decreased because we had a sharp decrease in the number of patients who were true positive from 32 to 7 because you raised the bar. Now again, reported values are around 31%. Again, literature says that at 48 hours, cutoff value 990 is not that great. Looking at the interval change in CRP at 48 hours, cutoff more than 90, positive predictive value of 26%. Now again, it matches with the literature, 30% is reported. So if we take everything into account, none of these values are actually very useful. And PPV of positive predictive value of 26% would mean that if we predict 4 patients having severe acute pancreatitis, only one of them will go into severe acute pancreatitis or complicated acute pancreatitis. So the question is then, what is the role of CRP? So I think the positive predictive value is very much questionable in case of complicated acute pancreatitis. The role of CRP is not that established, but we can use it another way around, because we have seen that the negative predictive value is more than 80% in all while using all these predictors. So can it be useful in clinical practice? So similar concept has been proposed by Lankesh, who said that actually harmless acute pancreatitis can be predicted by certain variables. So according to our study, if somebody has an NLR ratio of less than 4.7 at admission, Glasgow score less than 2, CRP is less than 150, 190 at 48 hours, or the rise in the CRP is less than 90, then more than 80% chances that these patients will not develop complicated acute pancreatitis. So in cases where there is a high suspicion of severity of disease, after 72 hours, CT scan should be performed. It's usually advised to do it at after day 7 because we want to see any complication that will be more evident. The minimum period should be 72 hours because you want to avoid injury to the kidneys. Patient with MCTI, if they have a score greater than 3, they should be closely monitored, and these are the patients who should be discussed with the ITU team and specialist center for their remote care. Now, like every study, we have limitations, and it was a retrospective analysis. CRP at 72 hours was missing in majority of the patients, so we have not used 72 hours CRP. Patients with incomplete information were excluded, which means that you can have a type 1 error, and it can affect the generalizability of the results. CT scan was not performed in every patient, so we have some patient missing a CT scan as well. Moreover, the reports were not reported by the two radiologists. Rather, it was used by reports were used to calculate the score. So that is another limitation. However, I would say this is the first ever study which has challenged that CRP at 150 or other different levels as a positive predictor of complicated acute pancreatitis. And it has stressed the importance of using the values of PPV and NPV. Most of the studies, they actually they use sensitivity and specificities to prove the predictive values, which is not right actually, because you should be using positive and negative predictive values. We also suggest that all these systems, they can be used in other way around, which is like the patients predicted to have a mild acute pancreatitis, they can be managed on ambulatory care basis. So CRP measured at admission at 48 hours has a very limited role in prediction of complicated acute pancreatitis. Due to high sensitivity, specificity, positive and negative predictive values, actually CT scan should be used based on a holistic assessment. So there is not a hard criteria that every patient should have a CT scan. So along with other scoring systems, CRP should be used to predict cases with mild acute pancreatitis. It will help in decision making for early discharge or discharging these patients, managing them on ambulatory care basis. We know that there could be possible impact on the hospital resources and costs. From 2017 estimation, a bed per day costs about £400. So if we can predict mild acute pancreatitis, discharge them early, probably we can save some resources and costs. I think we use this model in future and then base another study on this model where we discharge the patient with mild acute pancreatitis and then see what are the outcomes in these patients while making sure safety netting. Then probably this can be another future direction. Thank you very much.
Thank you, Khalid. Very interesting paper. Not because I mean, but it's quite challenging. Questions from the judges, please. Shafiq.
Yeah. So I think it's a good study. Pancreatitis especially still makes a big bulk of patients in both tertiary and secondary care. So I think, this is a retrospective study and you looked at the CRP and all those data, and a lot of this data is available as well. But what about, how do you decide on the basis of what parameters this patient is got a severe or mild pancreatitis? Although CT scan is due on the 72 hours, I think it's more a physiological score, which is physiological score that's more important. And I think new scoring in comparison with the other parameter will be important. That's the area that I would propose. But it's a good study. Yeah, it's good.
I would think this is just a comment, no question, probably.
Any other questions?
So, Ruben, yeah, I've got again, it's to some extent an observation rather than a question. I mean, I liked your conclusion in terms of reduced bed occupancy in spotting less complex pancreatitis, and that being a kind of benefit to the hospital and the system. I think what you could also do to strengthen that dimension of your conclusions was really to work out a reduction in average length of stay in terms of that patient cohort, because clearly all hospitals are under massive capacity pressure all the time, and if you can demonstrate bed occupancy reduction, that has a service capacity benefit as well as a financial benefit. But yeah, I like the kind of wider system observation rather than just purely focusing on clinical practice. So that's great.
Thank you very much. Thank you.
So my question to you would be, what is the best predictor before 48 hours? Because you take 48 hours, after 48 hours, many of them are good. All the scoring system, they are scheduled after 48 hours. So what direction should we in research in terms of getting a test before 48 hours on admission in terms of prognosis?
I think using the Atlanta classification again as a basis, because some people with acute pancreatitis, they present with normal vitals, they present with normal bloods, CRP would be not much raised. So any absence of systemic failure, any signs of suggestive of any system failure, these patients are probably going to have simple or mild acute pancreatitis. So in these cases, if they are not in pain, and we don't need admission for pain management, so these patients, they are unlikely to go into complications. So these patients can be discharged early. There is a concept, there is no one answer for that. I think it's more of a clinical judgment, but based on this study, we can say that any CRP less than 150 at presentation, probably these patients are not going to have complications. But again, this need to be proved by future studies. If we combine all these suggested 4 or 5 parameters of Glasgow scoring less than 2, again that is at 48 hours, but can Glasgow score at admission less than 2 be a predictor of mild acute pancreatitis, CRP less than 150, and combining all these 4 together, the sensitivity and specificity and negative predictive value will go quite high. So I think it will be another scoring system rather than all existing system, because in literature, all existing scoring systems, they have limitations.
Yeah, I think
final question.
Yeah, Yeah, no, I think, no, basically, as I said before, I think it's a clinical judgment and observational. The physiological parameters, that's important. You know, you don't admit the patient if they are not in pain or not tachycardic or not dry and dehydrated or hypertensive. You don't send the patient home if he's tachycardic or, kind of those pictures. So I think it's a general clinical as well as biological parameter which decides, and there's no single factor. I think it's still, I would, if I do the study, this kind of study in a prospective manner, I would include the patient's NEWS score and compare it with all the parameters. And the patients that we see on the basis of clinical judgment and clinical biological parameters in ambulatory care, and then investigate for over the next few days as outpatient basis in the ambulatory care for finding the etiology. And if they are doing well, then we'll compare with the CRP and all that, and then we can formulate in future a sort of risk scoring system where actually both the physiological parameters on admission or on first arrival or first encounter along with the biological factors or biochemical factors. So I would still go up to the basics. I think you don't admit the patient to ETU or ITU regardless of whatever the Glasgow score, unless they are hemodynamically unstable and in pain and very dry and dehydrated. We have a patient who presents directly with a severe hemodynamic changes, and they go straight to the ITU. And we have patients who come and stay overnight and go home next day because we don't have ambulatory care treatments. But I think it's better to see that those two parameters combined on admission. I mean, there's no on the first encounter, and then propose the risk scoring. But that will need a kind of study where you both compare between the biochemical as well as the physiological parameters on admission, on arrival or first encounter.
I think, Shivik, this is quite a new concept, because previously or as an undergraduate or postgraduate, what we are taught is that anybody having acute pancreatitis requires admission in the hospital because these patients can go off at any point. So this is totally a new concept that these patients can be managed on ambulatory care basis. This has not been proved, or this has not been even recommended, but definitely we need to see what are the outcomes of these patients who are managed on ambulatory care basis. So I totally agree. The patients with the NEWS score of 0 and not in pain, they don't have. But with the diagnosis of pancreatitis, we need to be a bit careful because we'll not be able to support by an evidence that these patients do not go into complications afterwards, after discharge from the ambulatory care.
Okay, thank you. We have to carry on. I asked the judge if you want to have a short break, 10 minutes, or you carry on. We carry on.
I'm happy to carry on, Ruben.
Okay.
What time will we stop, Rob? It's 11
Ruben. Yeah, I might not be able to continue beyond 11.
Yeah, that's the only issue.
Right. Okay, so we'll carry on then. So I understand, Sahir, are you there? Sahira?
Hi, yeah, I'm here. Can you hear me?
Hello, good morning.
Hi.
How are you? Are you presenting the COVID-19 paper?
No, I'm presenting the cholecystostomy paper. The number 6.
Okay. The number 6, isn't it? Okay.